Hey guys. Thanks Rod and all the guys at Bitcoin Park for having us out here. I am Rich Lassiter. I'm an ER doctor. I probably don't really belong up here because I'm in the hospital, right? I'm part of the system, but I am part of the Bitcoin Physicians Network, and that's why I'm here. I'm actually from Atlanta. I went to Medical College of Georgia for residency and for medical school, and that's a very famous place 1 week a year, this week, if you know about golf. I'm a Bitcoiner. I came for the number go up, and I stayed for the freedom go up. So I joined the Bitcoin Physician Network earlier this year, and that has motivated me to start the Georgia Bitcoin Council as well. So me and some of the guys in Atlanta are starting a advocacy program for Georgians. Obviously, we've heard all this for the last 3 hours about how the healthcare system is broken. I kind of identified 3 things that I think are the big problems that we have in healthcare. We have misaligned incentives, opacity of prices, and unrealistic outcomes. So misaligned incentives. I love this quote from Charlie Munger: "Show me the incentives and I'll show the outcomes." So we have different parties involved in the transaction of healthcare, from the patient to the provider, and we have all these people trying to extract value from that system, right? We have the health insurance company, we have the hospital system, we have the pharmaceutical industry, the malpractice industry, right? And then I, as the doctor, I want the dollars too, right? And the patient wants to keep the dollars in his pocket. So everyone's trying to fight over the dollars, and everyone's incentivized to grow their piece of the pie. This is more of the same, and I think I can skip because you guys have covered a lot of the topics I was going to have. But I do want to talk about, Andy touched on this this thing here, the medical loss ratio. So this is a thing I actually wasn't aware of until recently. I used the AI to help me build these slides, and the AI found this for me. But the medical loss ratio, this is part of the Affordable Care Act, and this requires the health insurance company to pay out 80% of what they collect in premium. And so, as an example here, if you have a $1,000 procedure and you're going to collect 20%, that's $200. But if you double the price, you get to collect $400, right? So the health insurers, as Andy said, are incentivized to grow the prices. And like, you wouldn't think that. You would think they would be lower, right? But they're not only incentivized to grow the prices, they're motivated to grow the share cost, right? Because there's all public companies, and so the real person they're trying to grow are the investors, not the patient. So we have price opacity, and anyone who's a clinician knows that none of us know what the prices are, right? The prices are, there's completely arbitrary. It'd be like if we all got, everyone in the room, we're all gonna fly to LA, and then once we land, they assign the ticket price to us. Like, yours is $500, and yours is free, and yours is $2,000, right? And then we all were on the same plane. So this is a big problem, and this is encouraged by the fact that someone else pays. So as we saw from Stuart's, the moving graph that he had there, how the patient portion has gone smaller and smaller over the years. We're all expecting, and all my patients in the ER, someone else is paying for this, right? No one knows the cost of anything. More the same of not knowing the price of the product. Okay, opacity is a feature. So this misaligned incentive of the health insurers and the hospitals being able to negotiate on the prices, right? Because none of us know what the price is. We can't know the $4,000 colonoscopy, right, versus the $1,200 colonoscopy if we drive for an hour. These things aren't available for most consumers to shop. I've had friends talk to me about they're going to have a baby and like they want to like price shop. No one can do this. There is no price list to look and see this system costs this much and this system costs that much. It just doesn't exist for any patient. And the system doesn't want you to do that because they can continue to negotiate amongst themselves for their highest revenue. Unrealistic outcomes. So most of society thinks that they should get everything back to normal. You have a health event, let's get complete recovery, right? I want to be perfectly normal at the end of this thing, and that's not realistic. And then, of course, we all die, and most of us don't want to acknowledge that fact, or at least a lot of the families that I see in the ER, the families don't want to acknowledge that. And then you have a loved one who's getting cancer care, and it's stage 4, and it's not looking good, and they've made no discussions about end-of-life care. And they show up, and what do? Everything, right? And I am the expensive place, right? I am the most, and Dan, we're the most expensive way to get healthcare in America. So I was talking a little bit earlier with Andy about this. So if a patient doesn't have insurance, will we take care of you? Yes, there's a federal law. We take care of everyone, whether they're going to pay us or not. But we're incentivized to sometimes spend more if you don't have insurance. Because, hey, Rod, you don't have insurance, and I have a pretty expensive test I really want to get done for you next week. Let's put you in the hospital, and then the hospital will pay for it, right? So not only does it get done, the hospital's not going to get paid, but it gets done at the highest cost of healthcare, which is being in the ER or in the hospital. And then this is the most expensive lie in healthcare is that we're all going to live forever. And we really should do a better job. And it's really sad to me when patients come in who have end-stage diseases, and they come in and they have not had that tough decision or that tough conversation. Even people who get enrolled in hospice programs, some people here can't see me. So people get enrolled in hospice programs, right? And then they die or they get near death. The family panics because maybe the hospice company didn't come out. Maybe it's some of the ones that are in Minnesota that were the fraud that was referenced earlier. But so they didn't have a good hospice nurse to kind of walk the family through the end of life, the dying that's going to happen. And the family panics and they call 911 and the EMS arrives. And they start CPR, and they bring them to the hospital. And maybe I keep them alive and put them in the ICU and spend $100,000, $200,000 more that doesn't need to be spent because this person was dying anyways, and the hospice company was supposed to be there to help them not have that big healthcare expense. So this all happens, by the way, every day in every ER in the nation. This is my job. This is what I do. And then, so fiat money. Of course, I forgot to ask this at the beginning. I was going to have everyone raise their hands for different things because we've been sitting for so long. So I do want to ask, raise your hand if you are a hospital-based clinician. So only a handful of us here. If you're a clinic-based physician. All right. And if you're a Bitcoiner, raise your hand. All right, good. I just want to make sure we didn't have any non-Bitcoiners in the room. So we're talking about fiat money here. So we've talked about how the money isn't good. And we know the money's not good. And we know that the money's losing purchasing power. And so there's really no cap. There's no incentive for the government to just not promise more and not spend more. So they can promise more and they can say, oh, we'll pay for this thing. One thing that is not going to get solved ever is unless we have a cap on the government's ability to create more money, we're going to just keep on just making up more money, dishing it out. So how does Bitcoin fix this? I don't know, actually. There's not a good solution to how Bitcoin... I really think that... I do want to skip ahead a little bit because we know all those things. But this... I want to skip ahead to the Hayek. So we talked... Oh, gosh, that far away? Okay. So this was... Who said this? I forget which one of the guys on the stage mentioned Hayek. Oh, it was Dr. Link, right? So Hayek. So I do not believe that we shall ever have a good money again before we take the thing out of the hands of government. All we can do is by some sly, roundabout way introduce something they can't stop. We have to take healthcare away from the government, right? They have meddled with the free market, and we have to take it away from them. So one way we can do that is by transacting in money that they can't stop. And then I hadn't been in Bitcoin Park before, so I didn't realize how low this was going to be. But at the bottom, Jeff Booth here, you cannot fix the system. You can't solve the problem within the system from within the system itself. So I think we're going to have to bring in this new system of Bitcoin. I'm going to go rewind a little bit and make sure I didn't miss something I wanted to cover. I did have another bit at the bottom here about the loss in purchasing power. And I think it was covered earlier today by Dr. Ramus. But we know what happened with the decline of purchasing power in the US dollar from 1913, and I think he covered what happened in 1913 was the creation of the Federal Reserve System. So the dollar's going to keep on losing purchasing power over time. So I did spend quite a bit of time with peers trying to figure out how Bitcoin is going to solve the healthcare problem. And so one of the problems that one of my peers pointed out to me was the lack of transparency in prices. And so if we had the ability to shop for the colonoscopy, for example, then people would compete on prices, right? And so as an example or a corollary there, MRIs, right? MRIs are getting more and more expensive every time. Well, they should be getting cheaper. Okay, maybe we've got some newer machines with more detectors, and so maybe they're a little bit better images, maybe a lot better images. But we still should have the older machines being cheaper, and we should be able to make these intelligent decisions and say, hey, I'm willing to go and get the $400 MRI instead of the $2,000 MRI. But we can't price that. We can't shop that because we don't know the prices. All right. So low time preference. We're obviously low time preference people here. So I think we do have a long-term future thinking. So if we do a little bit of our income stream in Bitcoin, we should be growing that purchasing power over time. Bitcoin is, of course, the first global free market. And so as we tie that free market into healthcare and growing in healthcare, that should be good for us as well. And I have another Jeff Booth. I really like this quote about the Bitcoin being the 8 billion people in service of 8 billion people. So once we all have the same money and we're growing our businesses in America and we're operating in India and everyone's working on this same foundation of money and everyone's incentivized to save their money, people will be less incentivized to spend it on frivolous things and they'll make better decisions with their healthcare purchases going forwards. And how else can we do this today? I think this was a question that you asked earlier. How do we do this today? Well, obviously you can use these two companies that sponsored the event. You can accept Bitcoin, so you could use Lightning just on your phone. Like that's one way you could do it to answer your question. John may have some more questions, some more answers for you, but you could just have a Lightning wallet on your phone and do this. You could run your own node and have a BTC Pay server on your own node. You can run Square Terminal, and then they're linking with Bitcoin Lightning payments now. And then, of course, we can spend with the DPC model, and I wish we'd had Dr. Goyle here to hear more about that. I, unfortunately, have zero understanding of that because I don't get to choose what anything costs, right? People don't choose to come see me. They choose to go to the hospital. I happen to be there when they show up. And then we can, of course, join the Bitcoin Physicians Network. And I know that a few of the guys, Dan and Mark, I think are doing some like televisits or some stuff apart from the hospital where you do get to do some of that pricing for yourself in that DPC. So fix the money, fix the medicine. I do have an example. I have a couple minutes left. Some of the misaligned incentives that exist, I practice at Emory University, not Emory University, Emory Decatur and Emory Hillendale. And here's a map of Atlanta. So I'm working over here at Emory Hillendale, and this is Emory University. And roughly 30 minutes on a normal time, maybe double that in traffic time. We have a patient with a medical emergency. Maybe they got a brain bleed, and someone in the transportation division of Emory decides we're going to put them in the air, right? We're going to use a helicopter to transport them. Like, this is crazy. I don't know if you guys have ever been a part of getting someone on a helicopter, but we do. There are reasons to fly someone, maybe, especially if you're a lot further away than 30 minutes. But it takes a while. So if I want to get a transfer done with an ambulance, pre-COVID times when there were more ambulance services and more of this happened quickly, it might take me an hour, half an hour to an hour for a reasonable transfer. And then post-COVID, it could be 2-3 hours sometimes. But usually it's gotten better, it's gotten faster. But I can probably get someone transferred 60 minutes. If I do the helicopter, it's going to be at least half an hour because the bird has to land. They have to get that crew inside. They always have different pumps. It takes forever. So we get the person in the air, so it's half an hour. So one of my colleagues, one of my coworkers, she lives a little bit further east. She's in the Piedmont system. And this is a 45-minute transit to go from Piedmont down to Atlanta. And on traffic time, double that. Her dad had a out-of-hospital cardiac arrest. He got a pulse back. They had him in the hospital. He took the helicopter flight from this distance here, and they got a bill. He had multivessel cardiac disease. He was going to get a bypass surgery. The bill was $76,000 for the helicopter ride. Where did that bill go? It just went into the garbage, right? He doesn't have health insurance. He's not going to pay $76,000. And what did he save, right? No one's going to pay it, first of all, but like, if we could have had a discussion, right? It could have been, hey, you can save 30 minutes by getting in the air, or you could save, $60,000 by taking an ambulance ride. We aren't able to have these discussions. The numbers aren't published, and no one has this sort of like hard conversations with the patients to say, hey, do you want to spend $70,000 for a helicopter ride, or do you want to just take ground? And by the way, he didn't go straight to the OR. The operation was the next day. Probably would have been reasonable to have been on the ground and not in the most dangerous form of transportation that we have in America.